All right, this is Dr. Nolan. Hope you're having a good day. Today's discussion is going to be on pressure waveforms that are generated by the heart. What I'm going to try to give you is a good explanation about how the actual waveforms are generated. In this case, pressure waveforms are generated by the heart. But I'm also going to discuss some other things that I think you need to know about. First of all, I'd like to tell you that when you look at the heart, you got to look at it in a little bit more of a global approach. A heart generates many different things, but we measure only a very limited amount. Okay. For one thing, we do measure electrical activity of the heart, but instead of looking at the actual pacer cells or myocardial cells, we really are only looking at the global function of all these cells put together using our EKGs. So that's one thing you have to take in consideration. We're not looking at everything. The other thing that the heart generates is it generates force, which is, in other words, it moves mass with velocity over time. So it does generate force. We don't have very good ways of measuring force. Indirectly, we measure the forces generated by the heart by using cardiac output measurements. The other thing that we have is that as a heart alters its volume, it actually causes volume shifts to take place from the atriums into the ventricles. It also causes volume shifts to occur in the ventricles, which then shift the blood into the aorta of the pulmonary arteries. And the volume shift then goes into the conduit vessels, where the conduit vessels not only accept the volume but also compress it, and that is also an important factor in diastolic pressure. The volume also shifts into the coronaries. So you got to take into consideration, and when we talk about coronary perfusion over the next week or so, this will become a little bit more clear. We have a very difficult time measuring volume, although that's really what we want to measure most of the time. The only way we can actually measure volume accurately is using echo, specifically 3D echo. We can actually use CT scans, although that's unless you're using a very specialized software to be able to pick up a cardiac event in between beats. It's very difficult. It can be done, but it's not as easy, and you're also exposing the patient to radiation, so it's not a normal modality that you would use for monitoring. So we don't often use volume as a way to assessing what's taking place in the heart, which is unfortunate because it actually is what is a more important factor than pressure. The heart also generates other things that most people don't think about. Is that the heart actually generates an electromagnetic field. It is pushing blood through it, which has iron in it, and as a consequence, because of that, it develops an electromagnetic field around it. This electromagnetic field is not talked about very much, but some people think that it actually regulates to a certain degree the brain's function. So health of the heart may actually affect the overall mood of the patient simply by altering the electromagnetic field that is generated. After all, the brain is a very big electrical factory, and as a consequence, alterations in the electromagnetic field can alter that overall function. The heart also generates heat as it pushes blood, which then pushes heat to the rest of the body. So decreasing perfusion will limit the heat to be dispersed to the extremities. And one of the ways you can tell that shock is taking place in patients is that they'll develop cold hands. So one thing to pay attention to. The other thing is the heart also generates velocity into the blood, and that's dependent on the contractile force and the resistance to the blood vessels. The heart also generates hormones. It also consumes fuel such as oxygen, sugars, and fatty acids, and we'll talk about cardiac energetics. This will become more clear. And it produces waste products including CO2 and metabolic waste. Now, the reason I'm sort of talking about this briefly is that I want you to sort of think that the heart is simply not just a pressure generator. It's actually a little bit more than that, and I think that's an important thing to think about once in a while. The heart also generates waves, and these waves then travel and cause the pressure waveforms that we actually measure. Now, waves that are generated by the heart are sinusoidal waves, okay, which means that they have a peak wave and in the bottom of the wave in a sinusoidal fashion. Okay, What we're looking at sinusoidal waveforms is that you can give them an amplitude, which gives you the top peak, which in this case we call systolic pressure, and the bottom peak, which is the diastolic pressure, and the mean in between these is considered the mean pressure. Of all the waveforms that are generated, the most accurate information can usually only be elucidated using the mean. So mean arterial pressures are by far, and mean venous pressures are by far the most accurate when you're looking at overall pressures. Now, the waves can actually be significantly altered by many things. And because these waves can be altered by many things, it can actually change the waveforms that are being generated, and that has to be taken into account. What things can actually alter the waves are resistance changes, so the diameter of the conduit is very important, the stiffness of the vasculature, the length of the conduit. Reflectance waves are also an important factor, impedance, and viscosity of blood. Now, when sinusoidal waveforms travel in the air, which is also, believe it or not, something that the heart does cause because it pumps against the actual lungs. As a consequence, you'll see every once in a while when a patient is being it's not spontaneously breathing, but is off the ventilator, you will see through the pressures inside the trachea via your pressure monitors, you will notice that there will be slight upward deflections on your monitor, which indicates the actual cardiac compressibility that's taking place on the lungs. So you are having a certain degree of compression of the heart on the lungs as a consequence. Now, in addition to that, what other waves are generated is when you generate waves, you can cause turbulence through the valves, conduit, or through the air. This generates sound, which causes the alveolar sounds as well as vascular sounds. If you don't think that there's vascular sounds, you can actually take a microphone and apply it to an artery on a patient, and you can actually hear the actual arterial pulsations through that, and it gives you the quality of how well the heart is pumping. Pressures are easy to measure, and that's why we use it using transducers or manometers, which are the preferred medical tool. The problem with it is that it has limitations, and I think that's one of the unfortunate things that we don't get trained well enough in our career, is that we're not told about the limitations of just monitoring pressures. In reality, what these inferred pressures are trying to tell you, to a certain degree, how much volume is being displaced. But the actual volume that's displaced, of course, has to do with possible effects of compliances of the actual structures, or alterations in resistance, or alterations in the length, reflectance waves. So all these are important factors when you're actually looking at overall pressure waveforms, and you have to take that in consideration, I think. Now, one of the things that we're going to talk about over the next 30 minutes or so is on pressure waveform concepts. And what we're going to try to go over is why are they important, what produces the waveforms, and how these are related to the volumes that are being displaced. First of all, I think you have to know what normal waveforms are, and then how these waveforms may be similar in different portions of the heart, and what you can actually determine clinically from these waveforms, and to maximally elucidate the maximum amount of information that you can obtain. And then I think you also have to begin to discuss what causes the alterations in these waveforms and their clinical significance. Now, why are they so important? Why we look at pressure waveforms so important? Because it provides you with a lot of information if you know what you're looking at. And that's the important part, is you got to know what you're looking at. Okay. Unfortunately, most of us just look at the systolic, the mean, and diastolic, and really don't obtain any further information by the waveform. But in actuality, all the waveforms, to a certain degree, are indicating to you how the heart is actually functioning. It's telling you the degree of preload, afterload contractility, and to a certain degree also the nature of the heart rate that's evident in that patient. Now, what makes pressure transducers as well as other non-invasive ways of looking at pressure is that it's a relatively easy technology for us at this point, and it's reproducible, and it's really one of the best off-the-shelf technologies that we have right now. Now, the waveforms are generated by only 4 systems in your whole body. In other words, pressures really can't be generated by anything else besides these. The major one that generates most of waveforms that are in the body is the heart. Okay, the heart is one of your biggest contractile muscles to shift blood around. As a consequence, is the one that generates most of the waves. But please don't forget that the additional muscle that causes generation of waveforms, which we call breathing, but also begins to affect other areas, including the spinal fluid space, the epidural space, okay, or any area where it's in direct contact with the chest cavity, are the actual diaphragmatic effects. So that's another thing that you have to consider when you're looking at waveforms. Blood vessels also, to a certain degree, contract, not rhythmically, but have some degree of contraction in the diastolic phase, which is important to maintain diastolic pressure. And the last one is the skeletal muscles themselves do contract against specifically the veins, which consequence helps improve venous return back to the patient. Every once in a while, you'll see that if somebody who is very limited in their preload, when you give them a non-depolarizing muscle relaxant, you see an acute drop in pressure after that. 2 reasons that could be the case. The smooth muscle itself is not being blocked by the non-depolarizing muscle relaxant, but what the skeletal muscle is actually doing is when it's relaxing, it's decreasing the afterload that the heart is seeing, as well as decreases the contraction on the veins, which basically increases the capacitance, and as a consequence drops the preload return back to the heart. So every once in a while, when you have a low preload state, you see that all non-depolarizing muscle relaxants will cause a slight drop in blood pressure at that point. In addition to that, remember that waveforms, there's really nothing else that produces waveforms in the body. The rest of the structures really don't do all that much. If you want to consider the GI tract is causing waveforms, that's a consideration of peristalsis, but it doesn't really cause overall, besides local changes in that tube, to the rest of the body. Now, the great majority of the heart generates waves by force of contraction of the atriums and the ventricles. These waves will give you a wealth of information about how well the heart is actually pumping. Remember that you're not measuring volumes, and you may be fooled if you don't take into consideration compliance of those atriums and ventricles that are taking place, as well as alterations in resistance and other factors which we'll talk about briefly. Now, what produces the cardiac waveforms? Okay, what I want you to first think about is we're going to separate the heart in between the right and the left. First of all, we'll start discussion about CVP, which is really a measurement of right atrial pressures. And we'll go on to talk about right ventricular pressure waveforms, followed by pulmonary arterial pressure waveforms, followed by what I consider the left atrial waveform, which is the pulmonary artery occlusion pressure waveform, which is also sometimes called the pulmonary capillary wedge pressure. The pulmonary capillary wedge pressure, in reality, is only done in the cath lab when a cardiologist actually takes a catheter and wedges it into a capillary. This is fraught with danger in the clinical area because that would actually erode to the capillary wall and would very likely cause hemorrhage into the pulmonary artery. So instead, we use the occlusion pressure technique using a balloon, so that's why we call it the pulmonary artery occlusion pressure. So if you're still using the nomenclature of pulmonary capillary wedge pressure, you really should change it to the PAOP, which is more consistent with what you're doing. Then we'll talk about left ventricular pressures and how that actually generates into the aortic pressures, and how the aortic pressures are different than the radial as well as femoral pulses, and how the oscillations are very important for you to determine why systolic and diastolic differences occur between these 3 arteries, even though the heart is pumping into these areas equally. Now, how are they related to volumes? That's an important factor. Okay, volumes would be the preferred measurement route that we would have because it would indicate to us really to a certain degree how much diameter sarcomere length is being reached. It also would tell us more effectively how much volume is being displaced and how much residual volume is left inside the heart. But in this case, it's very difficult to do that unless you're using the more advanced TEEs. Okay. So it does give you much more information about sarcomere preload, which would be accurate, much more accurate. It would give you the change in volume over time, which would indicate contractility. The problem is that it's clinically almost impossible. Instead, we create this idea of compliance curves, and from this we infer volumes when we're measuring pressures. So always remember that we're inferring volume changes by using pressures. Okay. The problem with this is that we're not really measuring volume, of course. The changes in the compliance in the ventricles can actually alter their pressures without changing the volume necessarily. And when we talk about the other hour on compliance of the ventricles, please refer to that section to make sure that you understand that very well. And the change in the resistance may also alter the pressure without really moving the volume at all. So that's another thing that may actually fool you. You may actually see an increase in pressures, and you may actually think that everything's okay. But in some cases, if you start somebody on like a neosynephrine drip or a levofed drip, the reason, especially levofed, has such a bad clinical name, such as leave 'em dead, is that when you inappropriately increase the dosing of levofed, you can actually maintain very good systolic blood pressures. But what you actually end up doing is you begin to starve the cells of actual perfusion and oxygenation, and the patient develops a severe metabolic acidosis and eventually causes cellular death, simply because you're not perfusing the tissues. And when you look at your PA numbers and you look at your arterial line numbers, they appear to be normal, which is sometimes can fool you simply just because you're increasing resistance. Now, what are the normal waveforms is the first part of the discussion. Is we'll correlate these waveforms with the cardiac cycle using EKG. I think that's a very important point because you begin to figure out exactly when diastole and systole begins. So using EKG can be very helpful to overlap with the waveforms to find certain valuable pieces of information. Okay. What I'll do is I'll try to break down the waveforms into diastole and systole for you. And as a consequence, you can, even if you don't remember exactly all the stuff that I tell you, you can actually work backwards and begin to explain to yourself what time period you're looking at. Okay, so I think it's very important for you to understand that waveforms are generated during different time cycles of the cardiac cycle, and it's dependent on what the ventricle as well as atrium is doing at the time. I will show you also how valves are an important part of the waveform and how they actually alter the waveform that you see. We won't go into how valvular dysfunction leads to waveform changes. That'll be discussed in about 2 weeks when we talk about valvular abnormalities, and we'll revisit pressure volume waves at that point, as well as actually how it alters the PA waveforms during valvular abnormalities. So for today, we won't discuss that. We will correlate the waveforms with pressure volume curves. I think that's very important. And later on, we approach this again, valvular pathophysiology. Now this is a drawing that I've made for you guys to sort of help you along. What I'm working first with is we're going to walk your way through from the right atrium all the way to the left atrium, eventually to the aorta. So the first cavity that as we enter using a PA catheter would be the superior vena cava and into the right atrium. What we call the right atrial pressures in clinical is the central venous pressures, the CVP. It's basically what you're doing is you're monitoring right atrial pressures. And the waveform that's generated from this, when you look at it at a scale of 30, is that you begin to see that there has A, C, and V waves. Okay, A stands for atrial contraction, so that's when you can see right here the P wave is generated. Right after the P wave is when the atrial contraction takes place. So these are the myocardial cells that are inside the atrium that are contracting and are causing this increase in pressure as the volume is being displaced and pushing that last 20% of volume into the right ventricle. So the A wave is an indication to you of atrial contraction. Right at the QRS is when you see the end of the A wave and the beginning of the C wave. This is when systole begins. Okay, so right at the top of the QRS is the point of systole beginning. And so you can always find the C wave as a consequence. As long as you just look up from where your QRS is at, that's where your C wave is at. The reason that's important to know is that the C wave is an indication to you of where of that pressure curve is really at the point of where ventricular filling is at its maximum. So it really indicates, in this case, the right ventricular end diastolic volume that's referred to. Okay, so when you're measuring CVP, you shouldn't be looking at just the total waveform, but you should just be looking at this point right here, which is where the C point is at right here. So this is really the more important value that you need to look at here. That's where your CVP is truly measured, as you can see by this red line. Okay. Now, in addition to that, following the closure of the tricuspid valve, this generates a C wave, and the C wave occurs simply because the tricuspid valve balloons back into the atrium, and so the atrium continues to refill, and as a consequence it produces this wave. Then the right ventricle will pump, and as a consequence will produce the V wave. The V wave is generated here, and that's an indication to that right ventricle is contracting, and also the right atrium is continuing to fill. This is C wave and a V wave do not tell you what's actually going on directly inside the ventricle, because the valve at that point is supposed to stay closed. So all you're really looking at is the actual pressure changes that are occurring inside the right atrium during systole of the heart. There's also the X descent, which follows the C wave, and the Y descent, which is followed after the V wave, and we'll talk about those at a later time. Okay. So what are the differences here when you look at these compliance curves? The right ventricular compliance it has an increased compliance compared to the left. As a consequence, changes in volume do not cause a change in pressure as rapidly. So it ends up being that the CVP tends not to be as accurate as a clinical monitor to show you changes in volume with concomitant changes in pressure. The next waveform that's generated is when you put the PA catheter into the right ventricle itself. And once you reach the right ventricle, now you're looking at intraventricular pressures. Okay. When you look at this, again, you see an A wave. The A wave is actually generated from the atrial kick. Okay, so this is the actual last 20% of volume that's reaching into the right ventricle. It's a pressure indication to you how healthy the atrium is. If the atrium is in atrial fibrillation, the A wave in here will disappear. So it's another way of picking up that you're in atrial fib or atrial flutter, is that you'll see a loss of this A wave kick. That as a consequence, you lose that ability to help fill the right ventricle adequately. You then see where the actual this point right here that I'm pointing at with my arrow is where the systole begins. This is when the maximal filling point, and that is mimicked by that pressure, which is also found at almost the same point as the C wave. You will see no dicrotic notch when you're inside the ventricle because, of course, there's no valve that's being noticing any pressure. But you will see that the pressure that is generated has to equal or exceed the pressure that's in the pulmonary artery. So this ventricular waveform is what actually generates the displacement of volume out of the right ventricle into the pulmonary circulation. So you really have to at least minimally reach the highest expected pulmonary artery pressure or exceed it if you have things like pulmonic stenosis. What you end up having eventually is that the end of systole occurs here. Okay, this is when the aortic valve, in this case pulmonic valve, would close, and we'll show this later on when we put the PA catheter reading on top of this. You can see your pressure over time curve here. the pressure over time curve consistent with the right ventricular waveform. So when you were talking about before on CVP, you notice that I didn't have in this drawing the actual pressure volume curves. The reason I didn't have a pressure volume curve on this is because pressure volume curves only apply to ventricles. Okay, so when we're looking at this graph again, now we're looking at a ventricle. In this case, we're looking at the right ventricle, not the left. So when you change that, you change the parameters in sense of pressures. The actual volume measurements are actually shifting the same amount of volume in stroke volume between the right and left ventricle. So that's one thing you have to remember, that even though the pressures are different, you are still displacing the same amount of volume in the right ventricle as compared to the left. So you expect to see that stroke volume change to be the same. What's nice about the pulmonary circulation is that it has a lot lower resistance. So as a consequence, you don't see that effect. Uh, you don't see that effect in the sense of increasing pressures rapidly. Okay. Next point is to show you how this waveform, that's your CVP, lives underneath this. Okay, so the CVP waveform is generated as a consequence to a certain degree by what the right atrium is creating, yes, but it's also affected by a certain degree by the actual filling pressures that they reach inside the right ventricle. So right here at the C point, that's why it overlaps directly and gives you the most accurate measurement of right ventricular end diastolic volume by using this right ventricular end diastolic pressure, which we call CVP. So CVP should be monitored here, right in this red line. The next pressure that's generated is the pulmonic artery pressures. Okay, the pulmonary artery pressures have to be generated by the actual volume displacement by the right ventricle. Okay, so one of the things that you will see is that a lot of times if you have normal valvular function, is that the pulmonary artery pressures between the red point here and the blue point here mimics the same pressure generated by the right ventricle, which is what this drawing is trying to show you. The red point in here is to try to show you where the pulmonic valve actually opens. That would be an indication to you of the end of the isovolumetric contraction phase. So this red point here correlates to this red point here, which is the pulmonic valve opening. The green point here would be equivalent to the mitral valve, sorry, the tricuspid valve closure, which is here, okay, which is really your preload point. So this line that's being generated, which is this pressure wave, indicates to you how effective the contractile force is taking place. And one of the things that we'll talk about later on is that this angle of attack can actually tell you a certain degree of the degree of effective contractility that's taking place in the heart. But this is the so systole occurs slightly before this area right here, and effectively because that's when mitral valve closure takes place. When we look at our pulmonary arterial waveform, we have a slightly delay, very slight, between the actual mitral valve closure point to the actual pulmonic valve opening point. Okay, that delay period will tell you how healthy the contractility of the heart is. The more healthy the contraction is, the lesser degree of time period change between the tricuspid valve closure and the pulmonic valve opening. Okay, this point between the red point, which is the pulmonic valve closure, to the pulmonic valve opening to pulmonic valve closure, which is the blue here, is consistent with on the pressure volume curve between the changes of the pulmonic valve opening here in the red to the pulmonic valve closure here. So that indicates to you that this waveform here that's generated, which is the actual stroke volume is generated, is to a certain degree affected by this pressure volume curve over here. So the overall health of the the overall health of the heart will actually tell you how well this actual emptying is taking place. If you have a limited stroke volume, what you'll see is that this waveform will become smaller, just like you would expect it would generate under pressure volume curves to become smaller. One thing that you do note is that on the pulmonary artery pressure is that you have a dicrotic notch. That dicrotic notch is indication to you that systole has ended. Okay, that's when the pulmonic valve actually closes. The actual pressure rebound effect that you see here, and the reason you get this upstroke, is not that there's more volume emptying into the pulmonary artery. It's simply that the pulmonary artery actually has some degree of rebound potential, which means it has an elastic component to it, and it compresses and actually maintains diastolic pressure. So the dicrotic notch is telling you how healthy the pulmonary circulation is to the rebound elastic qualities that it has. In some situations where you have extremely stiff arteries or calcified arteries, you will see that the dicrotic notch will almost not be visible simply because you won't have any dicrotic pressure or any kind of elastic pressure rebounding back. The other reasons you would see a loss in dicrotic notch will also be to low volume states inside the pulmonary circulation, where there's just not enough volume to squeeze on to cause that dicrotic notch to be created. So that's another way of watching if your preload is dropping in certain situations. The next point is the PA occlusion pressure, or the PA pressure is eventually the catheter goes in here and the balloon is inflated inside the pulmonary artery. And what we're looking at when we're looking at a PA occlusion pressure is we're really looking at the left atrial pressures. So as a consequence, when you put the balloon up, the actual PA occlusion pressure has to fall below the PAD. Okay, so PAD, which is pulmonary diastolic pressure, has to be higher than your PA occlusion pressure. There is no way in any clinical scenario where PA occlusion pressures will be higher than PADs. Okay, if you do see that, you have some kind of valvular abnormality taking place, which is faking your machine into believing that you have higher pulmonary artery pressures, occlusion pressures comparison to the pulmonary aortic diastolic pressure. So please don't be fooled into thinking that. If you ever see that that the PA pressures are higher, they are lower than the PA occlusion pressure, it would mean that flow is going backwards, okay, which is not really possible because the heart would then completely stop. But it could be indicating to you that you have severe valvular dysfunction, and you may either have giant A waves, such as in mitral stenosis, or giant V waves, such as in mitral regurg. So one thing that we'll talk about again when we talk about valvular dysfunction. Again, what you're trying to do is you're trying to measure the preload to the heart, and the preload to the heart, of course, is at the end of diastole. So again, where you're trying to measure this is right at the QRS, where the C wave is at. Okay, so this red line indicates to you right where the actual left ventricular end diastolic volume is taking place, which would indicate to you the PA occlusion pressure at that point. Now, what's nice about left ventricular compliance in comparison to right, because it has decreased compliance, is that it causes a much more linear relationship to take place. So for a small change in volume, you see a significant change in pressure. So one of the things that's nice about measuring PA occlusion pressures is that you begin to tank somebody up with fluids, you can actually see the pressure changes rapidly on your PA occlusion pressure. Versus in the right ventricle in the CVP, you would not necessarily see that until the person is on the upper end of the curve over here, which is then might be too late, and you may be pushing the patient into failure at that point. The actual pulmonary artery occlusion pressure is broken down into the same kind of nomenclature as you do as a CVP. Again, because you are in the atrium, so you're going to get an atrial kick. This atrial kick is due to the actual left atrial contraction, so it follows the P wave. The C wave is due to mitral valve closure, okay, which is also called the cusp wave. And then you see the left ventricular pressure is reflected back onto the atrium, and as well as volume returning back into the left atrium, which indicates to you the V wave here. Okay. Now the left ventricular pressure waveforms, if you ever were to get into the left ventricle itself, would give you the same kind of waveform that you would see for waveforms that are generated by the right ventricle. The differences again would be the height of the pressures. The height of the pressures are much higher, but the actual displacement volume is actually the same between the right and left ventricle. Okay, remember that. Okay, the pressures may be different, and the waveforms look exactly the same if you were to change the pressure heights, but the actual pressure differences are greater in the left because the left is pumping against much higher systemic vascular resistance compared to pulmonary vascular resistance. But the actual displacement of volume has to be the same between the left and right ventricle to maintain that balance that you need in life. Again, if you're measuring preload point, it would be right here. It would be right after the mitral valve is closed, and which the filling pressures are its greatest, because that's the greatest volume in the ventricle, which is the left ventricular end diastolic volume. In this case, it's the left ventricular end diastolic pressure. What you see in this graph here too is representation of where the aortic valve. This is where the mitral valve would close. The aortic valve would open up somewhere here, and then the aortic valve would open here, this is your isovolumetric line, which is consistent with what you're seeing here. So the green point would be here, the red point would be here, the aortic valve opening. This would be your stroke volume out, and eventually this would become the aortic valve closure point here, and then that would indicate to you the end of systole. Okay. The pressure waveform that generates the aortic pressures is generated by the left ventricle. Now, the left ventricle, at the minimum, has to reach that pressure or exceed it. In some kind of valvular diseases, you will actually see that the intracavitary left ventricular pressure is actually higher than your aortic pressure that's generated, simply because the resistance that's due to the valve. But in normal circumstances, if the valve opens, the ventricular waveform will actually mimic the actual height of the arterial wave. And that's very important for you to understand because it would indicate to you the health of the ventricle. So one of the things that I teach my master's students here is that I want them to look at the arterial waveform to try to determine the health of the ventricle. Okay, you can actually tell by this acuteness and rise of the actual arterial wave here is to a certain degree how well contractility is taking place. If it becomes more vertical, contractility is increasing, versus if it's sloping off, it means that contractility is getting worse. It also indicates to you how healthy the stroke volume is. The wider the stroke volume, the wider the arterial line will be generated. Okay. This phase between this, where I'm putting the arrow right now, is the mitral valve closure point. That's where you actually want to measure your pressures if you were to measure intraventricular pressures as to the maximal point of filling of the ventricle before contraction takes place. From here to this red point would be your isovolumetric contraction phase, and that also will tell you the health of the contractility. Once you reach this point, this is the aortic valve opening point. The aortic valve opening point is consistent with here on this pressure volume curve, and how that generates the actual stroke volume, which is what this is generating, the stroke volume. So your arterial line is really telling you how effective the stroke volume is on that patient. Eventually you reach the dicrotic notch, which is an indicator of the actual end of systole, which is also consistent with the aortic valve closure point. Now, the dicrotic notch that's generated is again due to the actual elastic qualities of the aorta, which is able to compress back down, and as a consequence, get a reflective waves back upwards, causing a positive deflection, and then help maintain the diastolic pressure. If you had a very stiff ventricle, that's either from calcifications or when they initially try to do aortic replacements with solid tubes, they found that the waveform that was generated dropped the diastolic pressure rapidly to zero, which caused coronary ischemia and quick death to the animal in the experiment. So they had to find some kind of material that was a little bit elastic, so it would at least give some kind of rebound and then help maintain diastolic pressure. So a rigid tube, actually you begin to lose this ability to give you diastolic pressure. So one of the things that you see with severely calcified aortas is that you have very high systolic pressures, but you at the same time have very low diastolic pressures. Now, I always want you to think about the similarities and the differences of these things. Pressure waveforms are very similar, and when you look at individual waveforms, right and left atrial waveforms are very difficult to discern between them. The only way you can actually tell the differences is the pressures are higher. The right and left ventricular waveforms are also very similar. PA pressures and aortic waveforms are also similar. But things that are also being displaced that are similar is that the volumes are being displaced in similar compartments. The right and left atrium basically have to push the same amount of volume to maintain a status quo. The right and left ventricles must also push the same amount of stroke volume out to maintain a steady state. Okay, and the PA pressures and the aortic pressures volumes may also have to displace the same amount of volumes equally. Now, what are the differences that you see? Is that you see that the pressure wave heights are different. So the pressures are different. The volumes displaced are not. Okay. What also is different is right and left ventricular pressures are also different. And you can also have differences in PA and aortic pressures simply because of differences in resistances. So compliance is also an important factor. So looking at similarities, what you look at here, the waveforms are still in for the right, which is this one here, which is CVP, and this is the P occlusion pressure on top. Still have A, C, and B waves. Okay, those are consistent. That's what's normal. The differences you're going to see is that the P occlusion pressure tends to be higher because of the compliance differences of the left atrium in comparison to the right atrium. Remember that the left atrium is slightly thicker, and it's also pushing against a less compliant ventricle. As a consequence, normally the P occlusion pressure tends to be higher than CVP. The resistances are different, and the compliances are different, and the pressure heights are different. Okay. The ventricular waveforms are, again, similarities-wise, is the waveforms are very similar. They still have the atrial contraction phase in both of them, and you'll see that one large ventricular contraction phase, but no dichrotic notch. Okay, the volumes that are actually being displaced by both these ventricles have to be equal to each other, which doesn't really seem to be right. But that's why I want you to keep it separate in your mind that volumes are not the same as pressures. So same stroke volume on both sides normally. The differences, of course, are due to difference in pressure height, which is where this picture sort of jumps out at you and tells you that. But that's really due to resistance differences as well as differences in the compliances found in the ventricles. Arterial pressure waveforms are also similar in their waveforms, and the volumes being displaced, believe it or not, are the same. Now, one of the things that you also want to take into consideration is that these are points of valvular closure. When you're looking at the PA pressures, you're looking at only pulmonic valve opening and closing, and you're looking at arterial pressure waveforms. You're looking at only aortic and aortic opening and aortic valve closure points. The differences, of course, are differences in height, and again, it's due to just differences in resistance as well as differences in compliances of the actual arteries. The arteries in the systemic circulation tend to be thicker in comparison to the pulmonary arteries. As a consequence, they tend to be less compliant, and as a consequence, generate a higher pressure in comparison to the pulmonary circulation. What can determine from these waveforms? Well, first of all, you can determine the physiology that's taking place in the heart. You can determine to a certain degree the preload of the heart. The preload indirectly is measuring the sarcomere length prior to contraction. So volume would be a much more accurate measurement, but in essence, what we use is the understanding that pressure is sort of related to volume. But one of the bigger mistakes that are made is that people are taught just to look at the mean of the waveform, which is not really true. It's not the mean that you should be looking at. You should be looking at the point where the C wave is being generated, and that's really the optimal point in time, which indicates to you either right or left ventricular end diastolic volume or right ventricular or end diastolic pressures. You can also infer from these waveforms of contractility indirectly by looking at the force of contraction, by watching the angle of attack on your ventricular waveform as well as on your arterial waveform. You sort of can infer how healthy the contractility of the heart is. If you see that the heart is increasing contractility, you'll see that the upstroke will be much more rapid. As a consequence, you'll get this almost like an upstroke in the first portion of the arterial wave. If you see it dropping off in the contractility, the waveform will become a lazy sinus wave. You see it will drop off at the angle of attack on your arterial waveform, which is a very bad sign to see, and something you should jump on when you see that clinically. Afterload indirectly can be calculated using SVR, although that's not really the best measurement in the world to admit, but it may give you at least an idea as to where your systemic vascular resistance is going. It's also, afterload is indirectly dependent on the aortic valve opening point, so that's where the afterload is actually measured. So you can actually tell by looking at the aortic valve opening point and by looking at your arterial waveform if the person has a low or a high afterload. If you see a low diastolic pressure, where it would indicate to you a low SVR, versus a high dicrotic pressure point opening would indicate to you a high SVR point. So preload, what I want you to do is measuring it here at these arrows. This is for CVP, and for your PA occlusion pressure. Remember that we use left ventricular pressures more accurately because they indicate to us a much more linear relationship due to the differences in compliance between the left and right ventricle. Contractility changes can be seen here by looking at the velocity of this slope increase. This is a part of the isovolumetric line. What I've done for you is where contractility is actually taking place. It's based on this blue line here. That's considered normal in this case, and this would be a situation where your increase in contractility, as you can see, becomes more vertical. And then you can see a person has a decrease in contractility. You can see the actual A line begins to develop this lazy S, and you can see that the stroke volume drops off. That's why the pressure sort of falls. As for afterload changes, you can see on this pressure volume curve, let me go back one time. You can see this correlation of the red line here correlates to this red line here. So this is a nice example because I've combined both the pressure volume curve with the clinical picture that you'll see in your arterial waveform as well as your left ventricular waveform. The next one is to give you an example of clinical situations where you change the afterload themselves. If you see an acute increase in afterload, okay, you would see that the stroke volume becomes depressed. So this is a situation where you see an increased afterload point. You can see that what happens in increased afterload, you also change the actual diastolic pressure point actually rises. Okay, but the downside to it is that it limits your stroke volume, so your actual peak wave drops. Sometimes you'll see a drop in systolic pressure as you increase the diastolic pressure. So you get a lessening of your pulse pressure height. If, on the other hand, you decrease the afterload, you get an increase in pulse pressure height simply because you will get a more effective stroke volume, as evidenced here, but you also will decrease the actual diastolic pressure due to decreased afterload. What can alter the waveforms pathophysiology-wise? Rhythm abnormalities can cause significant changes in your waveforms. One of the things that you'll see in atrial arrhythmias, such as atrial fibrillation or atrial flutter, is you'll tend to lose the A wave. Okay, in both your CVP and your PA occlusion pressure waveform. You will still see the C wave, but you will lose the A wave. Okay, you can also see changes in ventricular compliance, which can alter the actual waveforms. Instead of being a more of a linear relationship, it can actually become much more, if you have a decreased compliance, much more responsive to volume changes by increasing pressure rapidly, and we'll talk about this again when we talk about over ventricular compliance, so please review that. Ischemia may also be a big issue in the sense that it causes papillary dysfunction and decreases compliance, which also leads to a development of MR, and we'll talk about that again in valvular abnormalities as well as ischemia. And the right ventricle can also cause papillary dysfunction, the tricuspid valve, which can cause tricuspid regurgitation. Things can also alter the waveforms, include right and left ventricular failure, valvular disease, and changes in resistance that can occur. Waveform analysis gives you a lot of information, and you need to learn how to use it. Okay, one of the things that I begin to teach my students in clinical here is that you need to look at the waveforms before you start looking at the numbers. Okay, numbers don't mean anything if you don't understand what the waveforms are trying to tell you. Sometimes you'll have valvular abnormalities that are screaming at you, and a lot of people just look at the numbers and they don't pay attention to the waveforms, and as a consequence make many clinical errors. And so when we tie this in with valvular abnormalities, that'll become more clear to you, hopefully, and hopefully you'll prevent and try to explain to other people so they can use these modalities a little bit more efficiently. Limitations to anything about waveforms is that you have to understand the pathological changes that occur to the waveforms, that you're also not measuring volume. That's really an important mention over and over again, that anytime you're looking at these pressure waveforms, that you have to infer on the compliance and resistance that are taking place, and you can actually be fooled very easily if you don't take into that consideration. So remember, you're not measuring volume. You can also see clinically that ventilation can also significantly impact on your measurements of your heart. Remember that negative inspiration as well as positive pressure ventilation may actually alter the cardiac performance and actually alter the ventricular compliance of the heart. As a consequence, you do get changes in pressure readings simply due to alterations in breathing patterns, which have nothing to do with actual cardiac performance, but actually has to do with pulmonary health. You can also see acute changes in compliance due to ischemia or to multiple events, which we'll talk about in the time. And you can see also changes in resistance. I hope this has been a good lecture for you, and good luck. I will talk to you in the next hour, so thank you.